Okay. Also, in the chat box, I would like you to sign in there, in what program you represent our department, so that we have a running tally of who's all in attendance today. And I guess we could start with Tina with the morning prayer, and then we'll Shirley, you can start the conversation, I guess.
Good morning, everyone, and thank you for giving me the honor to say the prayer this morning. So, Creator God, just come to you this morning, first of all, to thank you for who you are and for what you do. I just want to thank you for allowing us to all come together this morning and to learn from Mr. Ted Hall, and to come here with open minds and open hearts to learn, so that we could help our community with these disorders, the opioid disorder and the stimulant disorder, and all these substance use disorders that our community struggles with. And we all are here because we want to help our community. We want to just come together and learn all that we can. And we just want to thank you, Creator God, for everything that you do. And we just want to just come here and first just be grateful. Just be grateful for what we are presented with today. And I also would like to say a prayer for all those that are in Washington, D.C. for the inauguration today. I would like to just ask for peace over our nation, peace over our community, and yes, all of that in Jesus' name, amen.
Amen. Thank you, Tina.
Yes.
Okay, we ready to start the presentation?
I believe Shirley was going to say something, I thought.
Did we lose Shirley?
She put a note in the chat that her audio isn't working.
I guess before we get started, one more item. If you can mute your phone or mute your mic, so that we don't get like calls and what have you. And then just keep that in mind. And then at the end we'll have questions, I believe, and Ted will be able to answer those at the end. Thank you.
One more thing, in the chat box, Mr. Hall said, posted all his attachments. If you want to save it to your computer, all you do is select a document, and you could save as a document.
Okay, it sounds like Shirley might still be having audio. Should I go ahead and get started?
Yes, go ahead, and then she could maybe hopefully get on at the end when you get done.
Sure.
Okay, thanks.
Go ahead and share my screen for the presentation. Okay, well, good morning, everybody. I want to say thank you very much for inviting me to do this presentation and share with you some of our experiences at Ho Chunk Nation. over the years with medication-assisted treatment and helping individuals with substance use disorders and underlying mental health conditions that it often times, I'd have to say most of the time, is self-treatment of some underlying mental health, anxiety, depression, trauma, or even like a life situation. So I want to start off by saying Aho hante e hija kishana hini karagiwi annaga haini chaiwada haipi rajada naske hatega hangade. And in Ho-Chunk, that's hello. Today I greet each and every one of you, and I'm glad to see you. My name is Big Heart. That's my Ho-Chunk name. My name is Ted Hall. So today I'm going to talk a little bit about, like I said, our journey with medication-assisted treatment. And as an introduction, you saw my bio. I'm a U.S. Public Health Service Officer assigned to Indian Health Service. I've been at Ho-Chunk Nation for 18 years now, and plan to be here for as long as they'll have me. So I'm a advanced practice pharmacist. So I'm a PharmD and also a board certified psychiatric pharmacist. But the advanced practice pharmacist is I'm operating under a collaborative practice agreement. So I have diagnostic and prescriptive authority for psychiatric and substance use disorders. So basically a non-physician medical provider. So go ahead and start off with disclaimers. So anything I shared today is basically the conclusions expressed for myself and not representing the Department of Health and Human Services, U.S. Public Health Service, Indian Health Service, or Ho-Chunk Nation, and I have no financial disclosures. So the objectives today are to define addiction as a primary chronic relapsing disease similar to diabetes or other chronic disorders. Just talk really briefly about some of the medication treatment options for opioid use disorder. Talk a little bit about our journey with Ho-Chunk Nation to, from when we started to where we're at now. Discuss methamphetamine use disorder because we're starting to see, we've been seeing a trend actually since 2018, more towards stimulant use disorders and methamphetamine particularly, and what do we do with that? And then identify some components of holistic recovery programs, so integrative approaches towards medication-assisted treatment. There's a lot of slides and I don't have that much time, so I might go a little bit rapidly. I have a lot of content, so you have it as a resource. So I'll hit highlights on slides that I'm gonna go by quickly, and I can answer questions at the end, as well as I'm gonna make myself very available for consults and phone calls and emails after this morning's presentation. So I'd like to start off with the general definition of addiction. So according to the Diagnostic and Statistic Manual of Mental Disorders, the essential feature is the individual continues using the substance despite significant substance-related problems. It is a cluster of cognitive, behavioral, physiological symptoms. The American Society of Addiction Medicine definition expands a little bit further, and I have highlighted in red the parts that I feel are extremely critical. So again, biological, psychosocial, and spiritual manifestations. An individual pathologically pursues reward and relief beyond what's expected. This is probably, for myself, one of the most important parts of the definition. So the individual has an inability to consistently abstain from the substance or alcohol. They have a diminished recognition of significant problems with their own behavior, so they don't see that there's a problem happening. It also involves cycles of relapse and remission, very similar to diabetes. We often see in diabetes an individual have a controlled A1C, and then at times they're not controlled at all. So I like to, have the analogy of diabetes because they have a lot of similarities. And then without treatment or engagement in recovery activities, it's a progressive and can result in disability or premature death. And I'd probably say should be replaced with will. So untreated, it has a very bleak outcome. So it is an organic brain disorder. So our cerebrum, which is that wrinkly part on the outside that's responsible for our higher functioning. But where I say that addiction, quote, lives is more so in the limbic system. So that's right in that center part of the brain. It's our emotional brain. It's responsible for fight, flight, and freeze and instant gratification. So our basic survival. We're also finding that in the cerebellum, which is our brainstem, there's also some addiction pathways that are forged over time. And that part of the brain is responsible for our involuntary functions such as breathing and heart beating. There's also a neurochemical basis of addiction. So all of these neurotransmitters are involved, but the primary ones are endorphins and enkephalins and dopamine. So endorphin actually stands for endogenous morphine. Our body produces its own version of morphine. So when we sprain our ankle or stub our toe, it releases just enough pain relief for us to seek attention. Enkephalins are more like our natural anti-anxiety and antidepressants. So that's a major neurotransmitter involved in all use disorders. And then dopamine is our reward chemical. So that is responsible for our arousal levels, and it's a critical chemical in addiction. So I like to even, when I talk to my patients, let them know that whatever substance you're using, whether it's alcohol, opiates, or methamphetamine, you're not really chasing that medication. What you're doing is that medication is causing a release of your dopamine, which is giving you the pleasure. You're just finding different ways to have that dopamine released. So what we're looking at in these functional MRI images is the top left grid is a sort of a quote normal brain, so someone who has no history of any substance use disorder. On the right hand side immediately to it is a brain of an obese person, and that's alluding to an individual who has a compulsory eating disorder. So you'll see that there's a lot less red, very little bit, and that's indicative of medium dopamine or difficulty feeling joy or pleasure. Whereas with the more high, the red zone is high dopamine. So the individual is experiencing normal pleasure and interest. So on the lower left, you see the brain of an individual who is addicted to cocaine, and on the lower right, somebody who is addicted to alcohol. And you see a lot more green, which is indicative of low dopamine. So the individual lacks the ability to experience pleasure. And you can even see in those bottom two, you see even some of the organic brain, some black spots where there's no neurotransmission. And this can happen, and what happens, this is even in early and late recovery, individuals do wind up, not experiencing pleasure in life as an individual who hasn't had an addiction. Epidemiology, so these statistics are a little bit older, but it was what I can find, but as the most recent, and so we can only extrapolate that the numbers are significantly higher than 2015. And then a really critical statistic here is from the CDC. 4 out of the 5 new heroin users today started out misusing prescription painkillers, either prescribed to them or not prescribed to them. We're starting to see a little bit more of individuals starting right out with heroin because opioid pain medications are not as available as they were 5 and 6 years ago. So here's some interesting statistics in graphical form. I'd invite everybody to go to that website. It's National Institute of Drug Abuse, NIDA, and you can see the trends since 1999. And we see almost a 6-fold increase in the total number of deaths from any opioids over since 1999. But if we separate out heroin, we see right around 2014, it started to really spike all the way up to 2017. 2017, it started to plateau a little bit. And in 2018, we see a little bit of a dip. And we like to think that has to do with our ability to have these medications that assist with individuals that are seeking help, as well as law enforcement activities trying to curb. But you'll see an interesting trend on the next slide with the rise in the psychostimulants, specifically methamphetamine, right around the same time. So what was happening is a lot of the Mexican drug cartels that were manufacturing and bringing heroin into the country converted over their operations to methamphetamine because it was much cheaper, and individuals were not seeking the opiates or as much as before. So that's where you see a lot of conversion right around 2017, 2018 to methamphetamine use, where individuals are using either heroin and methamphetamine both together, or they're using just methamphetamine alone and not using heroin as much. So interesting, around here in our community, there was this big idea of using methamphetamine to get off of heroin. And for some individuals that happened, but unfortunately then they wound up being on addicted to stimulants. And I'm on the Sauk County Overdose Death Review Board. And one interesting thing is we're trying to put out a public service announcement to the using community that when individuals are using methamphetamine and opiates together, it puts them at a higher risk of overdose death, because one is a stimulant, one's a depressant, and methamphetamine has a pretty long half-life, so it lingers in the system for a long time. So as the body is trying to reach homeostasis or normal functioning, and then somebody uses a dose of heroin, it far overshoots their threshold and puts them at a higher risk of respiratory failure and death. And that's not well known. We're seeing a lot more deaths happening that have both on board on their drug toxicology screens. And then also seeing a rise in cocaine as well. So cocaine and methamphetamine are starting to be predominantly what we see rather than opioids. So our tribal statistics, we're well aware that Native Americans use and abuse alcohol and other drugs at younger ages and higher rates than any other ethnic group, and that's been shown in many studies. Just one Northern Plains study showed that 61% of children report having a traumatic event, and 60% in that same study, 60% diagnosed with depressive disorder also had a substance use disorder. So I'm going to just keep hitting on that idea and concept that what I see and what we see most of the time is that substance use disorder is self-treating, underlying, and unmanaged mental health disorder. I'm in the Midwest, and this was part of a slide deck that I present to students that for the longest time, they didn't feel like we actually had a problem in our community. And a lot of other Midwest tribes were stating the same when I spoke to some of my pharmacist colleagues. So, but I think that if somebody feels like that's not a problem, I think they're just not aware of what's going on in the community. Part of the problem with the Midwest is that we really weren't equipped when it first started to peak in 2015, 2016. The coast had been dealing with this since the 1960s and had a lot of systems and experience in place. So unfortunately in the Midwest and in other parts of the country, we had to catch up very quickly when there was emergency rooms that were being inundated with overdoses and not having the staff or even the knowledge or understanding of what to do. Just wanted to really quickly touch on carfentanil. Carfentanil is actually a veterinary vet drug anesthetic. So there were times where carfentanil was causing a lot of overdose deaths. So we are aware that fentanyl is being laced in heroin, and you'll see in the picture it depicts a lethal dose of each one of those medications or drugs, and you'll see that they look exactly alike. So what will happen is there'll be fentanyl in the heroin, and since fentanyl is 50 to 100 times stronger than morphine, an individual using their normal dose can have an overdose. The problem is that one little grain of carfentanil is 10,000 times stronger than morphine. So there's no safe dose for humans, and Narcan likely is not able to revive an individual, and it can absorb right through the skin or regular latex gloves that are not the nitrile latex gloves. So we did a big PSA around our tribe. We put a lot of this exact flyer in most of the bathrooms and the gaming facilities and gas stations to be aware not to touch any drug paraphernalia, not even to pick up cellophane wrappers off the floor or off the side of the road, because oftentimes it's transported in that. So the internal motivation for continued use is often to not feel bad anymore. So it quickly changes from that feeling of euphoria or getting high to avoid getting sick, and then going from there to avoid withdrawal symptoms at all costs. So a lot of times there's a misconception that individuals are continuing to use because they just want to feel good. And in a sense, that's true, but it's not in the way that we think of it. They're actually just trying to avoid feeling like they're actually going to die, even though that opioid withdrawal is not a medically threatening condition unless they have an underlying condition. So it's a little bit of a busy slide, but I just wanted to introduce everybody to the opioid withdrawal syndrome, that there is an early phase and a late phase. And depending on which agent they're using, it can last anywhere from a few days to a few weeks. So in the beginning, you'll just see a lot of agitation, muscle aches, runny nose, tearing, yawning. And then at the later phase, about 2 to 3 days later after last use, you'll have a lot more GI symptoms like abdominal cramping, diarrhea, and all those previous ones just wind up getting more intense. And then, like I said, if heroin has got a short half-life, as we'll see on the next screen, so that has a short withdrawal syndrome of only a few days, but buprenorphine, such as Suboxone or Subutex or Methadone, have a much longer half-life, so the withdrawal syndrome can last anywhere from 2 to 4 weeks. And then actually on that last slide, post-acute withdrawal syndrome can last months, so we often forget about that. So there is a we really want to support the patient by treating chronic withdrawal symptoms like insomnia or physiologic anxiety that's going to occur because of the unmasking of the HPA access that was suppressed during use. So we want to pay attention to symptoms that are persisting beyond the expected 2 to 4 weeks. And unfortunately, that, with substance use disorders, the symptoms also result in a lot of aberrant behaviors that are illegal. So buying illicit substances and continued abuse in itself is a felony. We see a little bit of a distinction between crimes with males where it's more theft or violent crimes of assault. And then with females, it might be sexual solicitation, either for money or directly for the substance itself. Prescription fraud is reduced a lot with electronic prescribing, right from the physician's office to the pharmacy. But they're still selling and trading prescription medications like their benzodiazepines for either money or directly for illicit drugs. So this is the slide I was talking about. This is for the medical providers and the pharmacists out there. This is how it helps me determine when I'm doing an interview with a patient how long to prescribe their withdrawal supportive care medications. And one of the attachments that I included was our withdrawal protocol to assist people with abstaining long enough to have a Vivitrol or a long-acting Naltrexone induction. So you can see at the top, heroin is the shortest acting opioid, and at the bottom you see methadone and morphine having much more longer half-life. So if somebody tells me that they used heroin 2 days ago, or actually even just yesterday, but then they used a Suboxone strip 4 days ago, I'm expecting to not be able to, they're gonna not have a negative urine drug screen for opioids until at least 8 days after the last dose of their Suboxone. So it's just a guide to help me with decision making. So, and again, this is where this is a little bit more my opinion, and it's abstinence versus maintenance. So for opioid abstinence, naltrexone is a full antagonist. It completely blocks the opioid receptor. It inhibits any opioid effects, and it decreases and eliminates physical cravings. It also prevents relapse when taken daily as the oral medication or every 21 to 28 days for the injection. So as far as maintenance, buprenorphine is a partial agonist and methadone is a full agonist. They are designed for induction, stabilization, and long-term maintenance therapy. They do continue to stimulate the mesolimbic center of the brain as well, which can contribute to continued cravings if it's not managed at the correct dose. So the goals of treatment for opioid dependence in one study was a decrease in illicit opioid use, decrease in mortality, and reductions in criminal activity. However, I like to go much beyond that, and I'm trying to measure and keep a pulse on individuals' quality of life. Because in addition to abstinence, which is going to achieve some of these goals, I want to know if they're enjoying life. Are they having healthy relationships? Are they functional in their life? So the three main categories, as I talked about a second ago, was the full agonist, which is methadone, the mixed or partial agonist, antagonist, which is buprenorphine, and then the full antagonist is naltrexone. Methadone can only be administered in federally recognized opioid treatment programs. So they're highly regulated by the Department of Health and Human Services, DEA, and the state. And medical providers need special licenses and pharmacies to be able to prescribe and dispense these. So it's prohibited to prescribe and dispense methadone for opioid dependence unless it's out of an OTP. It's been used in treatment for over 50 years. There are some risks of abuse and overdose. So those are some substantial challenges with the methadone treatment. It has a very long half-life. A lot of times when I'm working with an individual that's leaving a methadone program or using methadone on the street, I'm having to work with them for at least 3 to 4 weeks for withdrawal medications in order to do an induction on naltrexone therapy. There's some cardiac risks along with methadone as well that we have to have be aware of. And sometimes there's an unintentional overdose, even at prescribed doses, because of an accumulation effect in the body. Buprenorphine is a little bit more widely available in the primary care setting with office-based treatment. So medical providers can get a special X waiver license from the DEA after a training, and physicians, MDs and DOs go through an 8-hour training, and the mid-level providers like NPs and PAs will have to go through a 16-hour course. And I actually took that course myself. After your initial waiver, it restricts treatment to only 30 patients for the first year. And then according to the Data Act of 2000, it was only 100 patients after that first year. However, in 2016, the CARA Act expanded that from 100 to 275 patients after 1 year to allow a lot more access to buprenorphine and medication-assisted treatment for individuals with opioid use disorder. It also allowed for expansion of prescription drug monitoring programs and the availability of Narcan or naloxone. I don't have it up here, but there was the Support Act of 2018, and that actually expanded prescribing to nurse midwives as well. So buprenorphine is a partial opioid agonist antagonist. The naloxone part of Suboxone is only there for diversion. So it doesn't actually do any blocking of opioids. It's very poorly absorbed into the body orally. So that's why it usually has to be given through nasal or injection. So it really is only there to deter individuals from mixing it up and injecting it, because essentially if they do that, they're giving themselves a dose of Narcan when they're injecting that Suboxone. It does activate opioid receptors similar to methadone, but it has a ceiling effect. So at doses higher than 16 or 24 milligrams, you don't get any more effect. Whereas with methadone, you can continue to dose increase and get more effect with each dose. Has a very long half-life, like I said, has to be absorbed sublingually, which is sometimes a barrier because technique will vary in how effective the treatment is for the individual. And target maintenance dose, according to the manufacturer, is 16 milligrams. However, I like to let people know with great caution, don't get individuals right to 8 or 16 milligrams if they're using if they're dependent on very low doses of opioids or heroin. An example of that is if somebody comes to me and they say, I'm only using about $20 worth or a point or 2 points of heroin a day. If we get them induced on 8 milligrams of Suboxone, they're actually going to feel that high and feel the opioid effect for a long period of time, and we just got them further dependent because they probably at that low of a dose of heroin use can be induced on 2 milligrams and sustained at 2 milligrams for their physical dependence. So we have to be very cautious with how we're administering buprenorphine, because we can actually create a situation where we're making them more dependent and they're actually getting high from the dose higher than they actually need. So just some clinical pearls and considerations. Methadone and buprenorphine require special labs because they're synthetic opioids. So if your lab panel doesn't include these and only opioids, there's a chance of actually missing buprenorphine and methadone being in their system. And if you induce an antagonist like naltrexone, you can precipitate withdrawal, or you can be prescribing Suboxone or other opioids or controlled substances without recognizing that they're on these other medications. Like I said, the very long half-life of each agent complicates inductions and taper to abstinence plans sometimes. And there's a high diversion potential, risk for selling or trading for illicit drugs with some of these medications. They do have street value. Naltrexone is a complete antagonist. The reason why it works is it looks like oxymorphone, but it has no agonist properties. There's an oral formulation where you take once a day, or long-acting, which is every 28 days. The individual must be opioid-free, otherwise you'll precipitate an immediate and intense withdrawal if they're not fully detoxed. So I know the package insert says that you wait for 8 to 10 days after their last use. We actually target their first negative urine drug screen for any opioids. And we also prescribe opioid withdrawal medications to target symptom management medications to assist in case there is a minor precipitation of withdrawal. With the oral formulation, we do have to watch out for renal impairment, as well as the oral formulation has a black box warning for hepatotoxicity. So I'll do a baseline of their liver function test to find out if I'm going to prescribe the oral naltrexone. The injectable formulation doesn't have a black box warning because it bypasses the first pass effect. So even in individuals who I'm prescribing Vivitrol for alcohol use disorder, if they have elevated liver enzymes that are not above 3 times the upper limit, I'll still give the Vivitrol to help them abstain from alcohol, because I know if they continue to use alcohol, they're going to continue towards hepatotoxicity. And there's a minor risk with the actual injection formulation. So some of my clinical observations for naltrexone is it does significantly reduce and eliminate cravings. And I have some data sets later on in the slide deck to really quickly go over to show that. It does wane after about 3 weeks. So I have every one of my patients come back after 21 days instead of 25 or 28 days. And I do bridge it with oral therapy. So I'll prescribe naltrexone 50 milligrams in addition to their injection. And the directions will say start taking 1 tablet no earlier than 15 days after injection and continue until next Vivitrol. So that way, as it wanes and they start having cravings and using dreams and sleep disturbances, that pill form will bring it back up to therapeutic levels and mitigate those symptoms. So inpatient detox is kind of challenging for opioid use disorder. So unless they're going to an inpatient residential treatment program that has detox as part of it, local emergency rooms and hospitals are not going to admit somebody for inpatient detox for opioids. So we developed our outpatient detox protocol, which again is one of those attachments, and it's really targeting each one of those symptoms to have them less intense and less severity of the withdrawal symptoms, and make them a little bit more successful in being able to achieve abstinence long enough to be able to be induced on Vivitrol. So for any substance use disorder or alcohol use disorder, we definitely need to have an integrated approach. All forms of medically assisted treatment must be paired with alcohol and other drugs of abuse and mental health therapy, again, to treat any underlying disorders. So we don't just have somebody on the medication. However, if somebody gets on the medication and then we do the referral to treatment and it takes a couple of weeks to get in, then we're still preventing overdose death by having them on Vivitrol. If they're still not engaging after about 2, 3, or 4 months, I'm having very strong conversations, but I still don't withhold the Vivitrol injection. But we always have it paired with counseling. And then considering recommending to 12-step support groups like NA or AA, and I recommend AA for individuals who have opioid use disorder. Going to NA and talking about their opioids sometimes will trigger that pathway and create cravings, and they'll sometimes leave that meeting, wanting to, or having a little bit more agitated or wanting to use. And then also even going beyond the 12-step programs, there's meetup.com. It's not like match.com. We're not matching people up like Cupid, but it's actually it's a peer support. It's a actual support group that doesn't have anything to do with addiction. So if you type in you create a profile with your email address and then you put in your zip code, you might find activities like kayak groups, hiking groups, knitting groups, things like that. So I invite individuals to get involved with social groups and social networks where you're not having to always start off with saying, hi, I'm Ted, I'm an addict, or tell your addiction story, and to try to start to also migrate into social groups that are support, don't have anything to do with addiction, and get beyond that, get into that well-briety in addition to recovery. So referrals to social services when appropriate. So a lot of individuals are transient or homeless and need just their basic needs met. So until they have a home and meals every day, it's going to be very challenging to stabilize addiction. And then incorporating spirituality, personal belief systems, and traditions. So it's extremely important to, as part of the recovery plan, to have individuals engaging in cultural activities like learning language, talking groups, drumming circles. I know we're not doing sweats right now, but as we have the COVID vaccine and hopefully able to loosen the restrictions on social distancing, just encouraging individuals to get back in touch with higher power and their cultural traditions. General concepts: get very comfortable with thinking outside the box. May need to incorporate parole officers or family members in the treatment plan with releases of information, of course, but just as much support as that individual can get, the more successful they're likely to be. Having an integrated collaboration is essential. So having the pharmacist, the nurse, even the registration staff need to be on board, because they're the first access to clinic and can create a barrier if they're not getting into appointments when they're actually in need of and motivated enough to seek help. So even in our own clinic, we did a lot of education, and our patient registration staff became the biggest advocates for individuals seeking assistance, and going back and talking to medical providers saying, hey, do you have any way to work this person in today, because they're trying to come in and get help today. And then case management, we do dedicate once a month where behavioral health clinicians, psychologists, psychiatrists, our nursing staff, our public health nursing, our pharmacists, nutritionists, we all get together for about an hour and a half, and we case our most severe and complicated cases. We do have releases of information and consent forms, and there's an example of our consent form that I have as the attachment. But there, within HIPAA and CFR 42, there are stipulations to be able to communicate between each other for continuity of care and safety of the patient. So some potential limitations, and I encourage each and every one of you to kind of reflect on what are some of the barriers or perceived barriers, real or perceived, or limitations you may have in your clinic. And then rather than say that's the reason why we're not going to do this, brainstorm together and reach out to other programs to find out some solutions to those in order to help the community. So of course, the federal regulation and restrictions, medical providers need their DEA and data X waiver training. There's potential for diversion and misuse if it's not monitored or prescribed correctly. We definitely need provider cooperation and buy-in. There's some cost to the medications. Integrated services can cause some, if you don't have that system in place already, then trying to just have that stand up. There's some controversial and stigma that beliefs out there, even among healthcare professionals or people in the health system, that you're just replacing one addiction with another, or that medications are addictive drugs themselves, which is true. However, if they're prescribed and monitored correctly, then it stabilizes the individual to become functional and have a quality of life that they don't have when they're at risk of overdose death from using illicit drugs on the street. Argument that society and medical professions are in effect endorsing long-term addiction or somehow enabling, and individuals on MAT can still relapse, and that is a true risk, but those are not reasons to not provide this service. So I have a whole slide dedicated specifically to stigma, and language does matter. So changing federal terminology regarding substance use, substance disorders. There's a memo that came out from the Office of National Drug Control Policy, previous director, Michael Botticelli, that basically we have to change the language we use. And the research has shown that people with substance use disorders are viewed more negatively than people with physical psychiatric disabilities. And even highly trained substance use disorder mental health clinicians treat individuals differently based on whether, and they found this out by just doing a case vignette, in which in one vignette they use the word substance abuser, and one vignette they use with person with a substance disorder, and there was a difference in the clinician's perspective and responses to those individuals. So why is it important? Why should we do medication-assisted treatment? MAT leads to a smoother transition to a drug-free lifestyle. We have to stabilize the physiological aspects and the physical components of addiction in order for the individual to gain more benefit from their mental health counseling and from their social restructuring. MAT can minimize their withdrawal symptoms. It controls cravings. The treatment program and treatment can include multiple areas of expertise, so that integrative approach. They have a potential lower rate of relapse. And essentially, it saves lives. When an individual is being managed on MAT, it minimizes their potential for overdose death and increases their quality of life. So real quick, just checking on the time here. So real quick, going on our Ho-Chunk MAT journey. So Ho-Chunk Nation is located in central and upper Wisconsin. So in Black River Falls and Baraboo. Ho-Chungra means the people with a big voice. There's approximately 8,000 enrolled members across the world. So we are in 14 different counties in Wisconsin and in Illinois and Minnesota as well. So we have 2 main clinics with 4 satellite health offices. So I have the Vivitrol policy as one of the attachments, but we have a satellite policy as well, where we're also providing Vivitrol at our satellite health offices through our community health nurses after an individual is seen in one of our main clinics and induced on Vivitrol in a medical visit. So in 2006, long-acting Naltrexone or Vivitrol was approved by the FDA for alcohol use disorders, so that was added to our formulary, and we had been using it since then pretty heavily. 2009, we formalized or we created a really preliminary protocol, and then in 2010, the FDA approved Vivitrol for opioid dependence relapse prevention. In 2014, we formalized a medication-assisted treatment program for alcohol and opioid use disorders, and myself piloted it as a collaborative practice pharmacist, and now all of our medical providers at both locations provide medication or MAT services and Vivitrol during their clinic visits. And it's not a special day in clinic, it's just worked into their everyday schedule. So the key components are, we use long-acting injection Naltrexone. We do use a little bit of Suboxone for pregnant moms or for individuals that are in Suboxone programs outside our system, and we want to bring them back into our behavioral health program. So, but we do that to we discuss Suboxone therapy and a taper plan to then convert over to naltrexone therapy. So even if an individual becomes stabilized on Suboxone and successfully, quote, completes a Suboxone program, they're going to experience extreme withdrawal cravings, or withdrawal and cravings after they stop their dose. And so I'm a big advocate for adding on naltrexone therapy for at least 12 to 24 months after buprenorphine or any opioid treatment. And then in 2019, we formalized our protocol into a policy and procedure, which you have an example of. So as far as methamphetamine use disorder, a big concept is everybody is using everything. So polysubstance use, as I was talking to in those early slides. And I'm a part of Wisconsin Society of Addiction Medicine, and we've had guest speakers from other ASAM speakers. And essentially, there's no FDA approved medications for stimulant use disorder. So we are using and have been using off-label use of extended release naltrexone, and I'm also using a camprosate, which is indicated for alcohol use disorder. So all of my patients with alcohol use disorder, I do those both in combination for every patient, but I'm also using them for my individuals who are struggling with stimulant use disorder. And I have pharmacology rationale behind that. So if anybody's interested, definitely give me a call or shoot me an email. I can go into that. But we want to do target symptom management as well. So second generation antipsychotics for the psychosis symptoms of hallucinations and paranoia are indicated. So we're adding that on as well. And then I have a link here to the SAMHSA treatment guide that was just released last year. And I was fortunate enough to be a part of their technical expert panel to contribute to this evidence-based resource guide. And it talks about the non-pharmacological interventions that are evidence-based for those behavioral health counselors that are targeted for stimulant use disorder. So I encourage you to become familiar with this. You can download it free off of the website at that URL. So real quick, going over the outcomes just to kind of show some of our clinical data is in 2017, I did present at the Wisconsin Society of Addiction Medicine. One of the attachments is our opioid use questionnaire or inventory, and it talks about the first 6 questions are asking about in the previous 30 days, how much have cravings interfered with their life? And then questions 6 through 12, I adapted from the brief pain inventory, and those are more quality of life questions about how opioid dependence has interfered with different domains of their quality of life. So the brief pain inventory is actually both reliable and valid across cultures and languages. So it's an evidence-based tool. So for those who aren't familiar with a radar graph, that outer layer, number 10, is the most severe interference. And then you want the interference to collapse closer to 0, which would be no interference. So what we're seeing on the red line is how much opioid interfered with these different domains at injection 1. So we're assuming previous 30 days of use. So worst is what was their cravings at their worst, what was their cravings at their least, what's their cravings on average, what were their cravings at that moment taking the questionnaire, were they able to abstain from other controlled substances or from the substance of choice, an opiate, or other substances. Then halfway down the graph, you'll see general activity, how much did opioid dependence interfere with your general activities of life, your mood, your normal day responsibilities at work or home, your relationships, your sleep, and your overall enjoyment of life. So you can see with the red line, there was a lot of interference. And then by injection number 2, so they had injection 1, coming in for injection 2, that's 30 days on Vivitrol, you can see how much that interference collapsed, especially with cravings on that right side of the graph. But it significantly improved their quality of life measures as well. Then we took a look and saw from injection 1 to injection 4. So Vivitrol takes about 3 injections to hit steady state. And you'll see on the left side of the graph that we had an even further collapse towards zero or less interference in their relationships, enjoyment of life, sleep was becoming restored. They were mending relationships, and they were finding joy in life. So the evidence-based model that is really appropriate to use and really effective for primary care is SBIRT, Screening, Brief Intervention, and Referral to Treatment, and it's a SAMHSA model. You can get some free training online from those two websites, but essentially it's what you're doing every day in life. So if somebody has diabetes and then they start having renal failure, we refer them to a nephrologist for dialysis workup. And so it's really no difference than somebody coming in for opioid use disorder and they're needing a referral to behavioral health or somewhere else. So really trying to normalize this and not make it distinct from what we're already doing every day in clinic and what we're doing with our patients with diabetes. So even if you don't have a behavioral health program, just becoming familiar with what your behavioral health resources are in the area to refer out to. So you can, in clinic, do your screening of the two item questionnaire. It's called TICS. You know, do you ever abuse alcohol or do you ever abuse substances? And then that will lead you on to, you know, and that's something the nurse can do when they're rooming the patient for vitals. You do your brief intervention as a medical provider, talking about the risks and then referring them on and letting them know there are options for treatment. I'm going to fly through these slides here. They're really for your reference. Motivational interviewing is extremely effective, and it can be administered by nurses, by pharmacists, by mental health providers. So it's really effective tool, and it's actually one of the modalities that's identified in that SAMHSA evidence-based guide. So clinical case management, this is kind of summing up the whole presentation. Integrated patient-centered approach is essential. Pharmacists, nurses, social workers, behavioral health clinicians, everybody needs to be on board, medical providers to support the individual. We all have our unique training and skill sets to help that person. So addiction is a very complicated biopsychosocial primary chronic condition of the brain, and it requires medical, behavioral health, social, and community responses. And then there's a resource that you may not be aware of, but it's available to everybody. So the Indian Health Service website, which is listed right there for the opioid use and pain website. Along the left side there, you'll see medication assisted recovery, which is like medication assisted treatment. So there's whole toolkits in there and resources. And then you can reach out to any member of the HOPE committee, the Heroin, Opioids, and Pain Efforts Committee, which I'm a member of, to gain even more resources. And the biggest thing you can ever do is just instill hope. Anytime you talk to an individual and you are able to, from a non-judgmental point, and removing shame and guilt and just treating them like a person, because they might not have been treated, be getting treated like that at home or in society, is hope is what's going to inspire and spark motivation for them to want to change. They're in a cycle of use and completely hopeless. And just the hope that you have in your voice as a medical provider or any caring healthcare professional can change an individual's life. This is my brother. He walked on in 2015 of a fentanyl-laced heroin overdose. I have that go by really quick because a lot of times I get choked up if I have it on there too long, but just in his memory, he had unmanaged bipolar ever since he was a little kid and self-treating with heroin. And unfortunately, there was an incident where he had used and nobody found him and he had walked on. So just remembering that each individual walking through your door is somebody's brother or father or sister or niece, and everybody deserves to get treatment just like they're walking through the door for their diabetes or high blood pressure. So here's my contact information. I invite everybody to, even after this presentation, call me, email me. I'd love to have conversations with you to help troubleshoot or figure out how to implement this in your programs. So I'm hoping that we have a little bit of time. We've got about a half hour, it looks like, for question and answers. Looks like Shirley might be trying to call in.
Hi, Ted. Can you hear me?
I can hear you now. Yes.
Okay. Yeah, I had to call in. Something happened to my docking station. It said, I don't know, I got to probably figure out how to get it fixed or something. So, well, thank you so much for that presentation. It was really awesome. And I learned way more than I knew before. So thank you.
Oh, thank you for having me. And like I said, I tried to cram a lot of information into a little bit of time, so I apologize if I went really fast.
Okay, Ted and Shirley, can you guys kind of elaborate on, you know, like when we have a patient that's come in and has a meth-induced psychosis, like how you guys handle that situation?
Go ahead,
Yeah,
Ted.
yeah. That was pretty challenging. We actually, in our facility, it caused our safety committee in our whole building to change some of their ways they do things. So we had to wind up having only one entrance where they have to go by security, because individuals were kind of running around the building in meth psychosis, not even here really for medical, because we have a building with our House of Wellness has not just medical, but also a pool and a gym and admin offices. But as far as the medical management of it, like I alluded to in that one slide, is I work them up just like any other patient. So their psychosis is chemically induced, but we have individuals who might present with an organic psychosis because of something like schizophrenia or bipolar mania. So I'm treating them the same way, where if they're having hallucinations or bipolar, or paranoia, I will start a low dose second generation antipsychotic, just like you would somebody with schizophrenia or bipolar mania, and try to help them with that, as well as antidepressants and anti-anxiety. So I guess my recommendation to healthcare providers out there with that same question is, don't hesitate to start antipsychotics. And if you don't feel comfortable as a primary care provider, then reach out to your psychiatry support or psychologist support, even your pharmacist. Even if you don't have board certified psychiatric pharmacist or somebody who like necessarily specialized in psychiatry, every one of your PharmDs that you have as a resource, and as a team, as the medical provider and the pharmacist, can safely initiate and manage antipsychotics in the primary care setting. So just utilize your resources and work as a team. You have lots of good knowledge, and I know that antipsychotics are scary, but for me, antiarrhythmics and cardiovascular medications are even more scary. Hopefully that helps answer your question, Emery. So essentially there's medications that can assist with some of that psychosis symptoms.
Yes, thanks. That does help. Thanks.
So, Ted, a person in the chat box said they had a patient who had a psychotic event in my office at another facility. I had a panic button under my desk to press for security, use it frequently as a MAC provider.
Absolutely. Safety is essential. And that's where every behavioral health clinician should have a panic button in their office when they're doing sessions. Because sometimes you can't tell right from the beginning that there's going to be a psychotic event or an aggressive encounter. So absolutely, safety is primary, but it's not a reason to not accept those individuals in the clinic. So, and that's where it's really important for even patient registration to have a little bit of knowledge or ask for nursing to come out to triage if they have an individual who is suspected of having some, we'll just say odd behaviors, and not letting them all the way back to clinic where there could be another safety breach. And if they're having a psychotic event, then follow your program's protocols and policies on that, and encourage them to come back to get treated when they're not having a psychotic event. The psychotic event is usually a result of current methamphetamine use and lack of sleep, so sleep deprivation. The individual might not have slept for 3 or 4 or 5 days, but once they have stabilized, that's when they bring them back into treatment. Just like we don't treat an individual who's intoxicated, they show up for their blood pressure visit, but they might have been drinking. They're not in a state of mind to make medical conditions or be safe for themselves or others. So that safety always comes first, but then we also want to treat and offer that individual the help they need. Oh yes, jail-based treatment I saw just popped in.
Yes.
So yes, I didn't get a chance to talk about that in our journey, and I meant to. So at our clinic, we have a good relationship with our county jail, and we actually are part of the consortium for the county that created some processes in our county. But essentially, I work very closely with the jail nurse and the jail medical provider, and we actually get individuals induced on Vivitrol while they're incarcerated. We'll supply the Vivitrol dose, but the jail nurse will administer it before the individual is discharged. And then before they're discharged, they also have their second Vivitrol injection scheduled at the clinic. So I encourage you to reach out to your local jail medical staff and develop some of those collaborations for MAT. And see what's available and what people are willing to do. There might need to be some training. We've actually done in-services where myself and the nurse who works primarily with me went down to our local residential treatment center in Madison, which is an hour away, to their detox. And we did an in-service on Vivitrol administration to their nursing staff. So collaborations, that integration doesn't only happen within your clinics, but also making partnerships with the resources in your community, including the jails, because they're a great resource.
The other thing, Ted, in the chat box, Monica is asking, do you have a psychotic protocol? And then she's also asked, saying that, do you have a protocol when working with detention centers?
We don't have protocols for either one of those. As far as the reason why we don't have a psychosis protocol is essentially because it winds up falling under the auspices of just general management and treatment. However, it might be beneficial for some programs to develop their own protocols and what they feel comfortable based on their own resources. And again, we don't have one with the detention center because we're part of the consortium and part of the discussion at the table. So we didn't necessarily need to develop protocols because it wound up becoming just routine daily business. But again, I encourage protocols. Protocols help everybody understand what's the process. No matter, if they've been there for a long time or they're a brand new provider coming on board, protocols are good guides on what to do. So I encourage those to be developed among your teams.
So another thing that some places do is they have MOUs or MOAs with some of the jails. So I think it's the Wisconsin people, Lacta Flambeau. Patty has a relationship with her county sheriff's office, and they have that system all set up at the jail. They start the Vivitrol there, and then they also have a curriculum they use. They use it with the inmates before they get out of jail. So that's more advanced stuff.
Yeah, exactly, and that's where it's going to be really customized to your programs and your relationships with your partners. So that's excellent, and that's great to hear. And of course with sovereignty, and we definitely have to have MOUs. We have MOUs with our local sheriff, MOUs with our local police, even though we have our own police force on site too. So MOUs are part of it as well. So you have your MOUs, and that's just for jurisdiction, but then you have your protocols in saying any one of our patients who receive MAT from us, we want them to have this curriculum. That's, so it's for consistency. So that's an excellent, and again, there's a resource for everybody on the call to reach out to Lacta Flambeau. I know Red Lake has a very strong program. So there's lots of resources out there. And if you don't know where to start, definitely give myself a call. Look at that IHS website for the medication assisted recovery toolkits, because there's resources there and people to contact as well. So we really want to get you plugged in and connected with everyone.
It does, for Red Lake, does Cynthia Gunderson have that one?
Yes, Cynthia Gunderson. And if you can't get a hold of Cynthia Gunderson because she's pretty busy these days, Kaylee Fretland would be able
Kaylee?
to. Yep, Kaylee, Kailee, Fretland, Fretland. She's a commander. So yeah, she's highly involved with Hope as well, and actually developed. She was in the chair for developing that MAT toolkit on the website.
Oh, she's asking me, can I repeat the name of that program? It's Lac de Flambeau. The Comas and Dodd is the name of the program. Okay, it's for Comas and Dodd, and then it's Patricia Thompson. I think if you just Google it too, you can find it on the internet. And Patty's pretty good about, like talking with you and working with you. Is there any other questions, any other issues that people want to talk about?
And for the medical providers and pharmacists on the call, again, write down my contact information, and I'd be glad to assist with even consults on individual cases or general questions about what medications I use and why I use them, or specific cases that might come into your clinic. And I live for this stuff, so you're not going to be bothering or interrupting me. So I definitely want to offer myself as a consult. I don't even like the word subject matter expert. If anybody tries to refer that to me as that, I replace it with subject matter experienced. I definitely don't know anything, but I would definitely love to consult with anybody who would like to reach out. And I see for Lenore, her comment is echo with a question mark. So I did reach out to Captain Gunderson. So she said that, not to officially announce it yet because it's still in the works, but there is going to be a substance use disorder Indian Health Service echo that's in the planning phases. So once that is officially approved and ready for launching and announced, I will send it to Shirley and Emery and Lenore, and to make sure that everybody on this call is aware of what the details will be. And the echo is going to be just like any other echo program, where there'll be a time slot for case presentation as well as a didactic part of it. So all I could say about it is just, watch for that coming down the road, hopefully very shortly.
I know University of New Mexico has an echo too. I attended it last week. Dr. Donald Warney was one of the guest speakers at that echo. It was very well done. Absolutely,
that's another resource. So I did work with University of New Mexico echo for pain and addiction a few years back, and I was on their expert panel along with Dr. Bott, who's a psychiatrist, Dr. Chris Ford, psychologist. So utilize the UNM echo as well. They're very, the IHS and UNM have a long-standing and wonderful partnership, and they're a great resource as well. So we want to have as many opportunities and resources for individuals out there to help support your community. And I see for sharing the PowerPoint, I did have the PowerPoint as one of the attachments in the chat box. But if anybody's having trouble downloading it, just email me and I can send it directly to you.
Okay. Any other questions? Any comments? So Emery.
Yes.
What are next steps for your project?
Well, what I'd like to do is to see if, once we get done with this presentation, reach out to some of the key partners that are on the call and see what their thoughts are, and try to schedule another Zoom call. Because one of the, when we started this conversation, me and you, Shirley, a few months back was, how do we implement the jail-based treatment and to get that going so that we can start, reduce that recidivism, that's going on with some of our people that are abusing substances, because they're just, a lot of times they don't follow through with what's mandated by the courts when they're referred down to us, and they end up back in jail. So I think we need to look at that and just have better, I said, more collaboration on some of these, like Ted said, in these high risk clients that are coming in, more collaboration there with White Sky, behavioral health, primary care providers. And I believe that is happening, it's starting, and just to move forward, I guess, and try to, see what we can do for that jail-based treatment in the short term.
So a suggestion too would be do you have tribal judges there? Do you have a tribal court?
Yes, we do. I did reach out to Eleanor Null. She's the tribal administrator, and I'm not sure if any of the judges got on, because I just see some of the first names on the screen. So hopefully they got on, but if not, we could also show them this presentation when they have time.
And we could include them in the next meeting, the next scheduled Zoom meeting, because I know from working in a tribal court system, a lot of times the judge is the one that, hearing the cases, and the judges and the staff should be more informed about this work, especially around the psychosis episode, because I had a lot of clients, a lot of people who would, I don't know if they'd have episodes, but they'd have like outbursts of anger during the hearings. And you really have to know what's happening with them to know how to deal with them in that system.
Yes.
So I think it would be good to include them in the meetings.
Yes. I agree.
And then your jail people, the sheriff or whoever oversees the jail.
Yeah, I see Randy Ellis was on. He's our one of our directors down there. He manages the detention facility for Rocky Boy here. So I'm glad he was able to attend, and I'd like to invite him again to that call, the second call that we'll have for the jail-based treatment.
Okay. So somebody can't access the slides. Oh, she put her email in there, Ted.
Okay, I'm copying it and I'm going to send that right as soon as we're done.
Are you saying something, Mary?
I'm just saying thank you.
Well, thank you for joining us. And thank you, everybody. I thank you, Ted and Lenore and Emery. Okay, so Randy says, let me know. Awesome.
This is a
It's
great
a great
beginning
to
serve
your community and help your people to heal. So, Ted, I just have to say, I really like how you draw the analogy between substance use disorder and diabetes, and how to look at substance use disorder as a disease rather than a behavioral, quote, health issue or a behavioral issue. And I think that's what's been happening in a lot of places, is there's a lot of judgment around people who use substances. And so it's about educating our communities too, so our community people understand about the verbiage and, and the more harm reduction way of looking at our community people. Because in my community in Red Lake and in surrounding areas, we've had like 60 drug overdoses within the past month or so. And so that's a lot. And we have to try to educate ourselves more and educate our people so they understand it too, and work with us, with trying to address the issues.
Absolutely. When I'm sitting in a room with a patient, and because I already see it in their eyes and I can tell by their body language, there's a tremendous amount of shame and guilt. And I let them know that, you know, we're human beings, and we try to avoid pain and seek pleasure just like any other animal in the animal kingdom. Unfortunately, we have some more sophisticated and more harmful ways to do that. So when life becomes overwhelming, something so uncomfortable or painful, whether it's physical, mental, emotional, you know, we seek out that self-treatment with alcohol and other substances, and then we get stuck, and it makes our problems that we're trying to avoid even bigger and more complicated. So I let them, you know, I try to let them know that, you know, you just chose the wrong manka, the wrong medicine, and now you're here seeking help, and now we're going to replace that medicine with other medicine that's healthier, and then on your road to healing and recovery. So I think that's a message that they need to hear as well, because they're just constantly getting judged and full of shame and not feeling worthy of even getting treatment, which prevents people to even walk through the doors. And then expand that message out to their family, to the community, to the healthcare providers, to the courts and the law enforcement. So it takes everybody though. So this is a great start. And I saw 50 participants, and maybe there were more because of room sharing, but absolutely, if everybody can from here just spreads that word even further, and that ripple effect, and it's so again,
Absolutely.
like I said, thank you for the approach that you are all trying to have with this, with normalizing it, and I tell people, these individuals are already coming to clinic. They're coming to clinic for, you know, foot sprains and diabetes care, and if we're not asking the right questions, or we're not treating them the right way, where they feel like they can open up to even admit that they want to seek help, that's on our part. That's where we need some, you know, we have to look at ourselves as providers and ask ourselves, you know, are we really doing service and justice and what we said we were going to do when we took our oaths?
So, Ted, you're recording, right?
Yes, it's still
So
recording.
can you send me the link?
Yeah, we might have to have a side conversation, because I've done Zoom recordings and they're very big files. So I may have to share it on like a Google Docs. But we can work that out logistically on the, you know, after the call.
Okay. Yeah, because what I'll do is I'll share it with the ATTC. They're out of University of Iowa, and then they'll put it on their website. So that's how you can access the recording, or you can email me too. And I put my email in the chat. Okay, is there anything else? Anybody else? Kawi? Kawi means no in my language. Okay, in my language, we say Gigawabamin Nagach means I'll see you later. How do you say it in Ho-Chunk, Ted?
There's no word for goodbye. There is just, you know, kind of see you later, but I'm not that fluent with Ho-Chunk, so you caught me. I admit I don't know the word for that one.
Oh, okay. Well, you'll find out next time you can say it.
I will. I'll find out until next time.
I see we got Mary Bigbo on the call. Maybe she could say an ending phrase for us.
Oh, that'd be great. Mary,
You want it? Can I hear that again? I didn't understand.
Oh, I was asking him how to say "I'll see you later" in the language.
Oh, muestas.
Muestas.
Muestas. Is that Cree?
Yes, it is.
Okay, awesome. All right.
Okay.
Well, thank you, everybody. Great presentation, Ted. Miigwech. Miigwech is Pinigigi.
Yes, thank you. I'm familiar with Miigwech.
Okay. All right. Awesome.
Well, thank you, everyone.
Okay.
It was a pleasure. Thank you for having me. And yeah, I hope you all have a great rest of the weekend. Don't hesitate to get in touch with me.
Thank you again, Ted. Later, everybody.
Okay,
All right.
thanks everybody. Thanks everybody for attending.
Sayonara.